But before that, I wanted to check with you people, how many of you are exposed to TAVR in this hall already in your centers? Can you raise up your hands, please? Yeah. A good number of people are exposed already. That's how the TAVI is becoming very popular after it got approved in our country too. And how many of you are interested to see this? What are the steps and basic things? Because some of you already know it, then you can always avoid some of the things. But hope all of you will learn something. That's why I planned it as a basic talk with step-by-step approach to explain the various steps in TAVR. Hope you all are okay with this. You want to listen to this talk? How many of you want to listen? Step-by-step talk, or how many of you feel already you're okay, good. I'm happy at least if you are in general, I'm telling if you want to make people say yes, there's a different way of doing it. If you want to say it no, you can different way of doing it. Anyway, I'm happy either way their hands are raised. So I will briefly cover up. I'll take about 5-10 minutes extra time for you to from the coffee break, which we are supposed to have it. And afterwards, we'll decrease the coffee break to 15 minutes and then we can reassemble back for the interesting STEMI sessions and neurointervention sessions. Dr. Sandeep Bansal sir, the senior most professor, is waiting to interact with us on STEMI. But before that, I will take you through the step-by-step approach in TAVI. Then this slide, again, I always keep showing this in hub and spoke models, always get to work as a team, and especially in tough times of COVID. And it's like all our friends working together and identifying patients for TAVR and also helping each other. Work-life balance, everything gets managed very well if you have the team approach. Some of my colleagues who are working in Remedy Aditya are also here, apart from my colleagues who are working in Apollo. We thank all our team members for making my life easy. If I'm able to do all these activities, it is because of active cooperation for all my colleagues. The patients are being taken care of there. As you've seen, I've designed this talk as basic, but we'll try to switch over and run faster in some of the basic steps. But what is TAVR is what is made this cartoon for a press actually, where the native valve is being replaced by the self-expanding or balloon expandable valve. I'm extremely thankful to partnership between FACS and Columbia Heart Valve Therapy Unit, especially Dr. Sushil Kodali here, apart from Martin Leon Ajay, who always support, because they were always stood as a rock. And before pre-COVID, a good friend came here and handled us. And in this part of therapy, when this therapy had some complications, it didn't pick up. But once he came and we did the procedures carefully, about doing 40-50 procedures without much of complications, then in and around all the hospitals in Hyderabad also got confidence, and that's how we learned this technique. And the beauty of this man is he treats patients as their own relatives and take all care to prevent complications. In the era where you had complications, once we did 50 procedures without any complication, that's how everybody got confidence in Hyderabad at least, and in and around. That's how the valve therapy program picked up. And we also learned around, so to learn some of the important techniques, went around Italy, went around Amsterdam to some other techniques. In these centers, they were very aggressive doing coronary and TAVR together within 1 hour. That's how we got more and more confident. And I learned this heart team concept in this Heartland Swiss clinic. It is really heart team. They all sit together, discuss, and decide which patients needs to go for surgery, which patient needs to go for TAVR. That's very important, which all of us can emulate and follow. I'm extremely thankful to my good friend, Dr. Samir Kapadia. He's now become the chairman of Cleveland Clinic, where it was our luck to go there because of him. Initially, we used to think that listen of it's great, but we had opportunity to go through and stop for some cases there. This is a hybrid cath lab which they have, and they follow the single femoral artery technique, which we learned from them. So it is good to know. And the Cleveland University opposite Dr. Atizani here is pioneered this technique of decreasing cuspal overlap view, where they were decreasing the complications of temporary pacemaker, but always a good friend and explains to us for any help. Also very thankful to all the colleagues across, especially IGPGF friends across the country. You have been referring patients for us to do these procedures. That's how the Apollo also was happy. It was in news where we did 5 procedures together in a single day before. And the institution support is also very important. We have a hybrid cath lab, which is nearer to OT, though sometimes luckily now we don't need, but the facilities are also important. We have some softwares where the CT gets imposed onto the cath lab, helps at least in the early learning phases to avoid complications. Now that you become more comfortable, you don't need to do all this, but that sort of superimposition will make us comfortable And if you feel that sometimes this valve is not expanded there, with this, you get more confidence to do post-dilatations and see that the valve expands well and avoid complications. So technology helps us, apart from the heart team and colleagues, to avoid complications in between. So I actually made some videos also for you as a live in case box, but for the sake of time, I'll skip. I was basically explaining. My colleague, Dr. Gokul Reddy, is here, a surgeon also here, and a cardiac anesthetist. The real heart team, it is there in the hospital. It is in the hospital, it is better. So this is a 81-year-old doctor. See the patients nowadays. Our patients also simulate West. He is post-CABG. He has now developed severe aortic stenosis, presented with LVF. Such sort of patients, actually, this therapy comes as a boon. Narrow QRS, but old antiseptal MI, echo, severe calcific aortic stenosis, and LV was reasonable, but then pre-op evaluation by echo is already covered in detail. I won't want to go into it, but evaluating whether it is tricuspid, bicuspid becomes important because we have some particular precautions we will follow, especially if there are bicuspid aortic valves, which I already told before. Doppler gradients assessment in symptomatic patient, it may not matter much. But once it crosses 4 meters, but in asymptomatic patients, we need to be careful in assessing. This is what I was mentioning. The CT TAVR protocols, all of us should become very comfortable with it. At least practice this short axis views. We are not comfortable, but if you keep seeing it daily, then probably you'll get into that. So where you normally also see this is a pulmonary artery, then bifurcation sometimes for the pulmonary thromboembolism, which you are very comfortable. Why you're not comfortable is at the lower down level. This all we can make out easily. Femoral artery levels, we are not very comfortable. I think that's how you keep practicing it, you'll get it. But we are okay with these long axis views because we generally see it in cath lab like this. The radiologists are seeing the short axis views. The long axis views, again, putting the proper analysis, proper resolution is important. The CT report analysis already told in detail by Dr. Ramesh just now. It's important to have the coronary heights in mind. This femoral artery evaluation was covered by Ranga. This is what I was mentioning. If the gain settings are not right, you will miss the calcifications. We were not comfortable before. We missed this sort of deep calcifications when the gain settings were kept very high like this. So it's important to work with these radiology colleagues where even they know the gain settings, other things better, but image interpretations, narrowings, we can interpret better. That's why combinedly, I feel we can always do a good job. That sort of calcifications by proper gain settings could not be missed. As is already shown, Ranga has already told us about ultrasound guidance. We have handheld devices like this, which have come, which is very useful. We need not carry the full machine here. Nowadays, we try to use this. If possible, you have a bigger machine, it's fine. Otherwise, those handheld devices will be also useful. And you check a femoral artery, both by cine as well as ultrasound-based punctures. If you are comfortable with, you can use it. And ultrasound-based thing which is shown by Ranga will help you to directly puncture the anterior part of the artery. But basically, there's no big deal in it. What we have learned right from my student days, that's the same thing what we are supposed to do. What we are doing is, basically, you are striking the common femoral artery, avoiding going down below the bifurcation or avoiding going very high up. Because if you go very high up, you get retroperitoneal hematomas and complications. You can't control the bleeding. If you come down, because these arteries will become smaller, these will need at least 5 mm vessels. So we need to target right on the head there. That's what basic femoral artery technique is. There's nothing new in this. So you need not get worried, perplexed, what is new happening in this large bore axis. It is basically the standard teaching, which is there ever since 1960s, is what is being re-emphasized now for you to practice. And you need not get so much puzzled by what is there in axis. But it's very important. All of us should take time and do this puncture properly, because most of the complications happen with the vascular axis only. Once this is done, rest of the procedure nowadays with more and more expertise, it's done faster. But even today, we should give maximum time to this. This video, I made it, actually sound is not coming, I think it's okay. Basically to show the two one arterial axis, one venous axis on the left side, and then on the right side we use it to take the valve inside. So this video basically shows that. Then I also recorded in the cath lab how the valve is being taken inside. Once you dilate with the dilators, once you put the sheath, see initial struggle at the calcification, sometimes it could be there. But again, with proper coordination with the wire and this, you take the sheath dilator inside. Then this is the steps of valve preparation. Basically, our therapy specialists from the company help us to prepare the valve in the lab because it has to be done immediately. Then once that is done, once this is being taken in, once the dilatation is done, before that you cross the valve with this. You are comfortable with, we generally use thermo wire to cross the valve. Once the valve is crossed, we take it deep inside, exchange that with a pigtail catheter and place this extra stiff safari wire or underquist wire, whichever we use it regularly, and exchange over the pigtail. The idea is again to keep the stiffer wire with a looped way so that it doesn't, the stiff portion doesn't injure the myocardium. That is the basic principle in it. And you form a loop and you should avoid the entrance of cardia through mitral cardia. Also, sometimes it could create trouble. And see, one pigtail is kept in the aortic root. The other one, stiffer one, is taken inside the left ventricle, and the valve is being threaded on with this thing. Then take it properly, and once you get across, this pigtail will also act as a landmark for us for the baseline lowest sinus, and then maybe 1/2 diamond below it and 3 mm below that. Nowadays, we want to come closer to annulus as possible. And you check with aortic root angio. Once you are comfortable with this, then probably that's where we tend to pace faster. Why we pace fast rate is we want the cardiac output to fall and the pressure should not fluctuate. Otherwise, each systole, the valve gets ejected out. So if you pace it, the ejection will be less, and the valve movements will be less. That's how the pacing is done when you are expanding the valve. Once you're comfortable with it, then probably at the last point, till 80% release also you can check, and you have the methods to capture it back in self-expanding valve. And then once you're comfortable, then you can release the valve. Once the valve is released, then the control is lost. But by and large, once you're getting this nose cone out also, you need to be careful. Sometimes this can get stuck across one of those leaflets, those valve things, and it can get back. So be careful while taking it out also. Once it is done, then probably we check the gradients again, the LV aorta, and then before gradients were there, now there is no gradient. Check the aortic root injection. There is no AR and no gradient. That's a good result. This is the final aortic root. After checking this, no leak into the AR and no parallel leaks. We also check on the echo also. And see, final check angio, the femoral artery is mandatory. After closure devices, again, sometimes you could develop constriction there, or sometimes a mild narrowings, which might need balloon appositions and dilatation sometime. So after putting the vascular closure device, which Ranga has already shown, we always check a final check angio. I think why this technology is becoming popular, especially balloon expandable valves, is basically stent-like. We are all comfortable expanding the with stents the same way you can expand these valves. That's how this will become very popular. And this patient whom I have shown, they did not develop any blocks. That is, the procedure is done. And pre-discharge echo and post-discharge echo. Sometimes we have patients who have LV dysfunction. Also, their LVs improve dramatically even before discharge itself. This man didn't have too much of a problem, but we have seen some patients where LV dysfunctions improved and the creatinines also improved in subsets. This had various subsets. Not only inoperable high-risk subsets cases, but we did cases of all these nature, elderly patients, severe LV dysfunction, CKDs with very minimal contrast. Their creatinines also improved post-procedure because cardiac output improves and it helps in better kidney perfusion. But take care not to inject too much higher contrast. The porcelain aorta, where surgeons were worried to put a graft or take incisions there, also was done. Bioprosthetic valve degenerations, valve in valve, that is being done commonly because patients will be worried to go for second procedure after the bad experience of the first surgery. And patients had bioprosthetic mitral valves. The coming again for aortic valve disease now happens sometimes also we have done. And bicuspid aortic valves again, which offline indication, but 30% of the time, 40% of the times, most of them are bicuspid. Sometimes they're associated ARs, there's no problem. We also seen associated mild, moderate regurgitations, mitral regurgitations also regressing after doing TAVR. That's why the latest TAVR classification, apart from the Eugene Braunwald, what is exertional triad symptoms. Now, what is latest is request all the residents to go through it. They might ask in the question exam also. Now they have separate classification of aortic stenosis. You grade them into 5, say, depending upon the back pressure changes of the aorta from the heart structures. Aortic, only LV is involved, LV, LA is involved, again, right ventricle is involved, pulmonary arterial hypertension developments, and all that. Finally, TR and atria are also dilated. That's the worst. So you have those subsets of patients, but all of them will regress if you tackle this patients with TAVR. So that's how the TAVR revolutionized, and especially the imaging multimodality concepts have helped in these patients. And we are all wanting to do this because our patient, this lady was referred from Nagpur, was sick, not able to lie down fast, went to vote. That's how that gives happiness, that we save this patient. The sick patients become active and lead a normal life. With this, I'll stop, and I thank all of you for making this TCT India successful in Mumbai last year. And July 26, 27, 28, 2024, we are doing it here in HICC. And Lupin promised us, all of us who are interested, if you can get back to them, they will get you there also. Thank you again. I finished, I think, in 15 minutes. I'll be happy to take any questions. Otherwise, we'll break for tea. Thank you. Sorry. Not only this, any other doubts we have in TAVR, or because now we'll close the session of TAVR and we'll go to STEMI sessions. We can ask freely any doubts which you have. I tried to show various steps and tried to stimulate your thought process, and then probably showed some complications what we can avoid. And but in future, all of you should learn this technology, because it's likely to come. More and more patients are likely to get benefited, and interventional cardiologists are also smart. Once they become perfect with that procedure, there are more indications will also start coming up. The new research is also coming up. Martelnia now proposes the concept of upstream therapy of aortic stenosis, where you need not wait till it becomes severe, and then even the moderate aortic stenosis subsets, which are likely to benefit by the procedures, are also being explored. Now we are also reaching an era where we are able to tackle this severe AR patients also. We have JenaValve, which is launched, which is only for isolated ARs also being done. Apart from AS and AR, we anyway do it, but isolated ARs also, we are almost coming to the clinical research phase. And that's why it's important for all of you to understand the concepts and do what is right to the patient. But one thing is, if you have any contraindications for the TAVR procedure, I'm not nowadays too much worried whether the patient is high risk, low risk, or moderate risk, because in all the subgroups of patients, TAVR is found to be useful. But you have to see whether any particular contraindications for doing a TAVR procedure. That's what is most important. The most important contraindication at this stage, I feel, is doing it in younger patients. We don't have data of more than 10 years. In future, the valves which last longer come, and then probably more studies come up in younger sublutions, we might do it. But as of now, as Ramesh mentioned, please don't advocate this therapy for anybody who is less than 60, unless I think we did 2 patients in less than 60 years. One was severe L dysfunction, CKD, where surgeon was not willing to touch, and very high risk. That is a life-saving procedure is different. But by and large, you should avoid doing these procedures in less than 60, that is age. Number 2, if you have any contraindication, specifically, you know that this may not be doing well for TAVR. Just because patient comes to you for TAVR, it's not your prestige that you have to do it. I'm never comfortable with this phenomena of low coronary heights, where you know that patients likely to get into trouble with coronary obstruction on table. People do this business of coronary chimneys, putting stents in the left main, doing TAVR. Then that is, if a patient is totally unfit for surgery, is different. But in low risk patients, please don't plan such crazy therapies. And this, whatever data we have in comparison of transfemoral versus surgical AVR, is only transfemoral. Again, crazy stuffs like going from IVC, going from other access, again, is not proven. In a surgically unfit patient is different. But if patient is fit enough, and our surgeons also do a good job, you can still send the patients for surgery if required. That's where the heart team approach comes. On the other hand, if a patient of redo surgery goes to a surgeon, unfortunately, some surgeons who are not very comfortable, don't have a heart team, try to do redo surgery. That's also not right, because redo surgery will be having higher risk, especially when the patient is 70 years plus. So you should avoid that also, and try to do what is good for the patients always, irrespective of the fact whether the patient comes to a surgeon or a cardiologist. I think with this, I wanted to stop here, unless you have any questions.
Severe AR without much molar calcium is in any role for TAVR in these patients. Patient is high risk, elderly, but predominant AR.
Yeah, that's what I was just telling. Generally, calcium helps to anchor these valves. So the calcium which is there helps us preventing valve pop-outs and proper positioning of the valve lift. In isolated AR patients where there's not much of calcium, that's where people are trying to do the Jena valve, which is approved for this purpose, just as an experimental basis and research basis. That's where it has anchors which comes out first. It anchors at the level of sinuses, and then it gradually gets relieved. If you have expertise with that, it is okay. I think that is done with a few 50 patients. Study has come out. It will come into the clinical practice hopefully in 1-2 years. But apart from this, we are not reached a stage where we can advocate this. If a patient is fit for surgery. If patient is sick and not fit for surgery, that's a different story. People are doing the balloon expandable valves with 30% of over-dilatations, which was demonstrated in one of the live case in TCT. Martin Leon again figured it out and was led a lot of discussion on it. That is not recommended as of now because it is always could lead to trouble, too much oversizing of the valve because the calcium is not there to anchor. So as of now, if you are expertise and Jena valve comes, I think we can try for doing AR. But otherwise, isolated ARs, we avoid doing as of now today. Yeah.
If there is a discrepancy between the coplanar view given by the 3-Menzio and the fluoroscopy on table, is there any SOP to adjust that? And also, sir, do we routinely have to image the ostium of both coronaries after the valve deployment to document that it is free of obstruction?
Those are two very good questions. Actually, he already has exposure to this. I think that's why he's asking the relevant questions. But basically, the coplanar view, what is that view is where in the pre-CT also you study all the three sinuses will come in one level so that it avoids a paradox. See in some angle, it looks like it is distorted, and when you're placing the valve also, it looks one lower on one side, other. And to avoid that, all the three sinuses should be same level so that you place the valve just 3 mm below the coplanar view. So previously we are only watching the coplanar view and taking only LA views. But with the advent of this commissural alignment technique where extreme RAOs we are going, that is delineating the membranous septum, which overlapped by the valve is leading to AV blocks. That's what the study shown. That's why this commissural alignment technique came with extreme RAO views. But why we are somehow more comfortable in still the coplanar view, checking in LA view. What we do now is we go to the extreme RAOs and also check in the coplanar view, but we do a commissural alignment view, but we also check in coplanar view. And if there is a discrepancy between the CT and the cath lab, we go by what we find in cath lab, because sometimes the patient's positions also will vary during the way CT is acquired. So in cath lab, there could be minimal 10-20 degrees variations, but finally our aim is to see how the sinuses are there on table, because you are deploying the valve on table. So you have to align little angular motion this side, that side will help us to see that you can have a pigtail and image in the aortic root you take and adjust the cath lab positions. If you have a 3D rotational cath lab, it is more easy to see which is the best view. Once you take aortic root in any way, you can see the angulations and fix up one angle where everything falls in one line. Coplanar is one plane, all the three sinuses have to be there. That's it. So if there's a discrepancy, we check in the cath lab and decide. And once you are releasing the valve, especially in self-expanding valve, it becomes relevant. Balloon expandable, anyway, you have less control. Then self-expanding, you see all the other end of the lower limits of the valve structures should be in the same plane. That is, I think, when there is discrepancy, go in what you are finding in cath lab. That is the answer to your first question. Second question, what you were asking was what to check about the coronaries. It's very important to check the coronaries, but indirectly you'll know it. If you produce a problem on coronary, it will declare itself. I had some interesting complications. I gave a talk in Sentient, I had it, where the coronaries get occluded, it will declare itself. Immediately it will present with cardiac shock, a cardiac arrest, hypotension, STT changes. So you'll know it, that is safe, but as a general protocol practice, we don't do selective, but we take aortic root shot to demonstrate that coronary perfusion is all right, and it's mandated to check aortic root angio before you close to document that there's no AR, no paravalvular leak, and also coronary perfusion is well maintained. And you also, in the end, check the femoral arteries. I think that you also get indirect evidence by the patients being stable, and you also check on the echo also if you're comfortable with the echo. But coronary perfusion, as you mentioned, checking is mandatory.